In this episode, we will continue our discussion of cyanotic congenital heart disease. Please refer to the previous episode, including the discussion of acyanotic conditions as well as coarctation with differential cyanosis. What are the risk factors for tetralogy of Fallot? Always remember D. George's maternal PKU and down. Describe the sequential pathophysiology of tetralogy. Always remember the first event and the most important determinant of prognosis is infundibular pulmonic stenosis. This will result in right ventricular outflow tract obstruction, again together with the stenosis, the determinant of outcome, and this can result in right ventricular hypertrophy. Second thing is a ventricular septal defect together with an overriding aorta. Now, what is the meaning of overriding aorta? Imagine that aorta is overriding to the right of the ventricular septum instead of being just totally on the top of the left ventricle, and this means aorta can receive blood from both right and left ventricles. Describe the pathophysiology of TET spells in tetralogy. The fluctuation on the level of right ventricular outflow tract obstruction in association with exercising, feeding, and agitation can result in worsening of the cyanosis seen in tetralogy. That situation is referred to as the TET spells. Again, continuing with the pathophysiology discussion, describe the phenomenon of pink or early or asymptomatic tetralogy. Even though we discussed tetralogy as one of the right to left shunts, after the first couple weeks of life there will be no shunting from the right to left ventricle, and therefore the patient will be asymptomatic or pink. Pink means no cyanosis, and this is the pink tetralogy. Now, what happens before and after this period is associated with cyanosis. Before first couple of weeks, the pressure in the pulmonic system is still not dropped enough, so we have a high pressure system, and therefore some degree of shunting, that is the right to left blood movement across the VSD, is possible. Also, by the progression of the tetralogy and increased pressure in the pulmonic system, gradually the shunt would reverse, and instead of moving from left to right across VSD, it will become the right to left shunt, like the Eisenmenger stage of the pure isolated VSD. However, none of these could happen if the degree of pulmonic stenosis and right ventricular outflow tract obstruction is so high that the pressure remains high before the right ventricular outflow tract. And that's a condition, in that situation, the neonate will keep having the cyanosis. As you can see, why we discussed the degree of obstruction on right ventricular outflow tract is the most important determinant of symptomatology and prognosis. True or false? Tetralogy of Fallot is usually a cyanotic condition with severe cyanosis at first day of life. That is false. Most of the cyanotic conditions, with one exception, are not associated with severe cyanosis at first day of life. What is that one? Only in D-transposition of great arteries we expect severe cyanosis in the first hours of life. That is among all the cyanotic congenital heart diseases. Now, if the patient belongs to those with mild tetralogy, what would be the symptoms? That's in the case of non-cyanotic kid. Presentation will be just dyspnea and fatigability and possibility of those TET spells, usually beginning after age 2. Once more, what's the most important correlate with the degree of cyanosis? The degree of right ventricular outflow tract obstruction, or the degree of pulmonic stenosis. Once more, the degree of cyanosis correlates with the degree of right ventricular tract outflow tract obstruction. Describe the pathophysiology of change in the murmur of tetralogy during the TET spells. Well, TET spells are associated with external stressors that result in increased pulmonary vascular resistance. We know that increased stenosis will be translated in decreased flow and increased transvalvular gradient. Now, if we had a pulmonic stenosis without ventricular septal defect, like an isolated pulmonic stenosis, increased transvalvular gradient would result in increased murmur of the pulmonic stenosis. But because in tetralogy we have a second outflow for the right ventricle, and that is the ventricular septal defect, pay attention that this time the direction is from right to left, contrary to isolated VSD. This time, increased severity of stenosis of right ventricular outflow tract would result in silencing of the murmur of pulmonic stenosis. I cannot emphasize on this fact enough. In isolated pulmonic stenosis, increased stenosis would result in increased transvalvular gradient and therefore increased intensity of the murmur. But in tetralogy, because of the presence of VSD, increased stenosis of right ventricular outflow tract would result in fewer flow across the stenotic valve and softer murmur, to a point that in very severe TET spells we may not even hear any degree of pulmonic stenosis murmur. Now, between the murmur of pulmonic stenosis and that of VSD, which one is considered the main murmur? In general, the main murmur of tetralogy is that of the pulmonic stenosis. Let's move on to the next pathophysiologic change, and that's the effects of squatting. What's the effect of squatting on the murmurs of tetralogy? Okay, what does squatting do? Squatting increases the total peripheral resistance, right? The systemic vascular resistance. This means the left-sided pressure, that intrachamberal pressure of the left ventricle, would increase. That means there will be less flow from the right to left. Therefore, the murmur of VSD, that holosystolic murmur at the lower left sternal border, would be silenced by squatting. There is less shunt, in other words. However, because there is less shunt, the right ventricular outflow would be the only tract for the flow outside of the right ventricle. Therefore, the main murmur of the pulmonic stenosis would increase. So please remember the effect of the TET spells, that increases the resistance to the right ventricle, versus the squatting, that increases the resistance to the shunt across VSD. Do you remember from our discussion in coarctation that what are the manifestations of congestive heart failure in the infancy? When there is feeding difficulty, that manifests itself with tachypnea, shortness of breath, sweating, fatigue. These are the manifestations of exertional dyspnea for infants. What other auscultatory finding, in addition to the murmurs of pulmonic stenosis and VSD, are possible in tetralogy? Because of the pulmonic stenosis, the P2 component of the S2 may be absent. Vignette for differential diagnosis. We have a kid with upslanting palpebral fissure, furrowed tongue, and a harsh systolic murmur. What is the diagnosis if this infant has fixed splitting S2? Well, fixed splitting S2 in an infant with facial and dysmorphologic features as described of Down syndrome will indicate presence of ASD as the ostium primum type, and the mechanism of harsh systolic murmur would be the common atrioventricular septal defect seen in the endocardial cushion defect in association with Down syndrome. Now, if the same kid with these morphologic features of Down, such as furrowed tongue and upslanting palpebral fissure and harsh systolic murmur, has a single as to what is the diagnosis, this is tetralogy of Fallot. What's the cause of harsh systolic murmur here? That is the pulmonic stenosis. Describe the diagnostic workup for tetralogy. The best and first test always in all congenital heart diseases will be echocardiography. And if you are asked what is the most important test for treatment planning, always remember catheterization to determine the pressure and O2 saturation gradient across the lesion. True or false, we do not have any findings in association with right atrial dilation or enlargement in tetralogy. That's theoretically possible because the point of obstruction is downstream of the right atrium. However, that's not the hallmark of ECG or chest X-ray findings. What is the findings in ECG? We usually have right ventricular hypertrophy and right axis deviation. What are the specific chest X-ray findings? The most important finding is defined as a boot-shaped heart, and that is the right ventricular hypertrophy that transforms the apex of the heart so that it looks like a boot-shaped heart on imaging. However, pulmonary vascular markings could be increased or decreased depending on the stage of the disorder. Remember that at least at initial stages we have decreased pulmonary markings. However, after a while, because of the ventricular septal defect, meaning increased flow to the left side of the heart, the backward flow to left atrium and pulmonary veins may result in pulmonary congestion. Never forget that the findings of tetralogy and earliest symptomatic manifestations in infancy or childhood is those of congestive heart failure. In addition to initial assessment with echo, ECG, chest X-ray, and catheterization, what other workups are needed? Evaluation for associated conditions such as the risk factors, Down, D-George's, Catch-22 findings, and possible complications. Now, what is the recommended management for acute TET spells? The urgent intervention is to do whatever we can to increase the systemic vascular resistance so that the shunting from right to left is decreased and the flow across the pulmonary artery is improved. That means we can consider a knee chest position, which is a variant of squatting. We can consider alpha agonist or beta blockers. Never forget that beta 2 causes decreased systemic vascular resistance, so we consider beta blockers. And of course, we provide oxygenation to further improve the oxygen delivery. Now, for the cases that are infantile and symptomatic, before the surgical consult, what's the first medical treatment? Alprostadil, the prostaglandin E1, to prevent closure of ductus arteriosus. Again, remember that if ductus arteriosus is open, that has to be maintained open in almost all of the cyanotic congenital heart diseases, at least before the surgical intervention is managed, the condition. What are the temporary and definitive interventions for the management? A temporary balloon atrial septostomy is attempted before the final definitive management, which is Blalock-Taussig shunt. So just remember the 4 steps. Management of TET spells with reducing the flow across the VSD by increasing systemic vascular resistance and oxygen or morphine if needed. Then temporary measures with balloon atrial septostomy, and then surgical Blalock-Taussig shunt. Before these interventions, alprostadil is to be attempted to maintain patency of ductus arteriosus. Now, given the fact that tetralogy has this first pathophysiologic event as pulmonic stenosis, and we have discussed the ventricular septal defect as an isolated acyanotic condition. I would like to discuss isolated pulmonic stenosis. Here we need to be able to differentiate these three conditions from one another. So the first question is, what are the common risk factors for this pretty uncommon cyanotic congenital heart disease, pulmonic stenosis? Always remember Noonan syndrome, William, Alagille, and congenital rubella. Do you remember the findings seen in Noonan syndrome? Think of Noonan as a syndrome that has features of Turner and neurofibromatosis because it's associated with short stature and webbed neck, but also is associated with cafe au lait spots. Other findings include down slanting eyes and low set ears and hypertelorism, similar to trisomies. So think of Noonan as a combination of neurofibromatosis, trisomies, and Turner. Cardiac defects are also seen, including pulmonic stenosis. Now, what findings do you remember in Williams syndrome? The most important one in cardiology to remember is supravalvular aortic stenosis in association with hypertrophic cardiomyopathy. But the other hallmarks of Williams syndrome is this elf-like feature and over-friendliness with strangers, as well as hypercalcemia. Do you remember the genetics of Williams? It's a microdeletion syndrome associated with impairments on chromosome 7. In addition to heart defects such as pulmonic stenosis, what else do you remember from Alagille syndrome? It's a condition associated with infantile cholestasis. It's a cholestatic syndrome. What are the findings in auscultation? We have this systolic ejection murmur on the left upper sternal border logically after an ejection click following S1. What do you expect to see on imaging of pulmonic stenosis? Right ventricular hypertrophy and post-stenotic dilation. So what conditions should be considered in differentials of this systolic ejection murmur in second left intercostal space? Either isolated pulmonic stenosis or the syndromic type associated with other genetic features as seen in Tetralogy, Noonan, Williams, Alagille. Remember, on the aortic stenosis, we could have these same murmur findings, but in the second right intercostal space. Give an example of a condition that we can have functional overflow on the pulmonic system. That's atrial septal defect. That is, without having pulmonic stenosis, we could hear the murmur of pulmonic ejection murmur. Remember, in the discussion of coarctation, we mentioned the concept of critical coarctation. Now here we also have the critical pulmonic stenosis. What are the findings of this critical type? When the cyanosis is present at birth or at neonatal period, and if you're asked what is the reason we categorize this pulmonic stenosis as a cyanotic condition or right to left shunt, what's the answer? Here's the critical point. Do you remember the patent foramen ovale, in which increased pressure in the right-sided chamber could result in a shunting of blood with the risk of paradoxical emboli moving from right to left? This is the reason why pulmonic stenosis could be associated with right to left shunt and cyanosis. This is a hallmark of the critical pulmonic stenosis. What is the treatment in this situation? Patency of ductus arteriosus capped by prostaglandin E1 before surgical correction. The surgery is the balloon pulmonary valvuloplasty. So once more, what's the exact indication for this pulmonary valvuloplasty? Early cyanosis, exercise intolerance, and severe stenosis, that is the pressure gradient more than 40 to 50 millimeter mercury. So once more, if you're asked what's the ultimate management, the answer is transcatheter balloon pulmonary valvuloplasty. Next, we need to discuss the D-transposition or dextrotransposition of great arteries. The only cyanotic congenital heart disease that is necessarily associated with severe cyanosis in the very early hours after birth. What are the risk factors of transposition? Maternal diabetes is the greatest risk factor, but another risk factor is DiGeorge syndrome. Describe the transposition of great arteries. It is atrioventricular concordance, but ventriculo-arterial discordance. That is, right atrium and right ventricle are connected to each other, but aorta runs anterior and to the right of pulmonary artery, because aorta is connected to the right ventricle and pulmonary artery to the left ventricle. What is the hemodynamic system described in this method? Always remember that even though it looks like the left and right systems naturally and normally are parallel, they are actually series. But in the transposition, they become parallel. That is, two parallel, totally independent systems running in parallel with each other. This is why it is considered perhaps the most severe form and incompatible with life if at least a couple shunts are not present. True or false, presence of a PDA could be life-saving in the case of transposition. No, usually an additional shunt such as an ASD or VSD is also needed. Remember we mentioned in tetralogy the degree of obstruction in the right ventricular outflow tract is the most important determinant of prognosis. Now, what's the prognostic factor in transposition? The shunt. When transposition is considered critical or unstable, if the shunt is these small shunts such as PDA or ASD, and when it is stable, when we have a more solid shunt like VSD. What's the significance of epidemiology of transposition? It's the most common cyanotic congenital heart disease of neonates. Now, you may remember from our episode on coarctation that we discussed the anatomic localization of coarctation based on the findings of differential cyanosis. And we mentioned there that there are certain cyanotic conditions that could be associated with reverse differential cyanosis, and this one is the example of reverse differential cyanosis. Describe the pathophysiologic mechanism of reverse differential cyanosis possible in TGA, transposition of great arteries. Well, remember that left ventricle has oxygenated blood. This left ventricle pumps into pulmonary artery in the transposition, right? And then pulmonary artery from and via the patent ductus arteriosus brings this oxygenated blood to descending aorta. And therefore, the parts of body that receive blood from descending aorta, that's the lower extremity, receive more oxygenated blood, but the parts of the body, that's upper torso and upper extremities, that receive the deoxygenated blood of right ventricle via the malpositioned aorta would demonstrate cyanosis. This is a picture, almost a mirror image of what we see in coarctation. So here we have differential cyanosis, the differential cyanosis that affects upper extremities, not lower extremities. Also, if you are asked what can cause more severe reverse differential cyanosis, remember if there is any type of left ventricular outflow tract obstruction such as aortic stenosis or coarctation of the aorta, that can contribute also to the reverse peripheral cyanosis. Now, what is the hallmark of transposition in chest x-ray? Narrow mediastinum and narrowed heart base. That's described as egg on string sign. What is the auscultatory finding? In addition to the possible murmurs of the existing shunts, we have a single S2. Why we have single S2? Because the aorta is in front of the pulmonic artery in transposition, we do not hear the P2 component of S2. Remember, in pulmonic stenosis, we also have single S2. but for a different reason, which is the stenosis of the valve. Long auscultation may also show the findings associated with congestive heart failure, which is together with severe or reverse differential cyanosis, the other common clinical finding. True or false, it's possible for transposition to have no murmur. That's true if there is no shunt like VSD, even though it will be very unstable type transposition, usually not compatible with life. So as you can see, and as we discussed in tetralogy, the presence or absence of murmur could be a dynamic phenomenon, could be absent initially, then worsen, and then present later by pulmonary hypertension, as we discussed in tetralogy, or here, depending on the presence or absence of a reliable shunt, it could be audible or absent. Why I emphasize on this is because there's so many overlaps in the clinical findings of all of these cyanotic conditions that maybe just one statement in clinical picture, such as reverse differential cyanosis, or theta spells, or improvement with squatting, or cyanosis at early hours of life, or association with Williams syndrome, that could be just one statement that help you diagnose the condition. Compare and contrast the epidemiology of tetralogy versus transposition. While we mentioned transposition is the most common cyanotic congenital heart disease of the newborn, we meant that it is the most common cyanotic condition that's associated with cyanosis at birth. That's the newborn period before 28th day. However, if you are asked what is the overall most common cyanotic congenital heart disease of childhood, that is tetralogy of Fallot. Now, how do we analyze the pulmonary vascular markings on chest X-ray of the cyanotic conditions? Well, remember, any condition that's associated with some form of obstruction on right ventricular outflow tract would be associated with decreased or absence of pulmonary markings logically, but conditions such as transposition, in which the stronger left ventricle pumps blood into the pulmonary circuit, would be associated with increased vascular marking on the pulmonary circuit. Why this can pose a confusion or challenge in differential? Because that may sound like an acyanotic congenital heart disease. However, presence of cyanosis is ruling out the acyanotic conditions in which presence of the left to right shunt would be associated with increased flow in the pulmonary circuit. How do we approach the management of transposition? Well, if there is a ductus arteriosus that is still patent, we try to keep it patent by giving alprostadil, PGE1. However, and as I mentioned, even though we categorize TGA as a PDA-dependent cyanotic condition, we need a more reliable or a secondary shunt, and therefore, especially if early surgery in the first few days is not plausible for whatever reason, we need to create a secondary shunt, and that is achieved by digging a hole in the atrial septum, the balloon atrial septostomy. What is important about the surgical definitive treatment? Which is either atrial or arterial switch, should be attempted within first 2 weeks of life. What's the overall prognosis of transposition? It's a two-step surgery, and each one of the surgeries have 50% rate of mortality. The combined probability of mortality just because of surgery, unfortunately, is 25%. We have mentioned several cyanotic and acyanotic conditions, congenital heart diseases, in association with DiGeorge's syndrome. Can you mention what this catch-22 and DiGeorge's syndrome stand for? C stand for the cardiac abnormalities such as VSD, tetralogy, and less commonly transposition. A stand for abnormal facial features such as micrognathia or retrognathia, low set ear, long faces, short philtrum. T stands for thymic aplasia. C stands for cleft palate. Always remember that DiGeorge's is one of the velocardiofacial syndromes with midfacial structural abnormalities such as cleft palate. H stands for hypocalcemia because of the parathyroid aplasia, and 22 is the number of chromosome in which the long arm has this microdeletion. Okay, moving to Truncus arteriosus. Now, what's the pathophysiology of Truncus arteriosus? Failure of the aorticopulmonary septum formation. If you are asked which one of the cyanotic congenital heart diseases are almost always associated with a ventricular septal defect, what's your answer? Tetralogy of Fallot and Truncus arteriosus. So if you happen to hear a whole systolic murmur in the lower left sternal border and you do not have the symptoms of tricuspid regurgitation necessarily, you are either dealing with Truncus arteriosus or Tetralogy of Fallot. Compare the degree of cyanosis in Truncus arteriosus versus transposition. While in transposition, the cyanosis is severe in the very first hours of life, in Truncus arteriosus, the cyanosis is mild. What's the reason? Because we have total mixing of right and left blood being pumped into a single arteriopulmonary trunk. We have compared the level of pulmonary blood flow in all of our cyanotic congenital heart diseases and acyanotic ones. What is the level of pulmonary flow here? Well, it's not a condition with pulmonic stenosis, but specifically it's a condition similar to transposition in some ways, with excessive increased blood flow into the pulmonic artery, and therefore we have increased pulmonary markings in chest x-ray. We have early pulmonary edema and symptoms of heart failure, as well as pulmonary hypertension. Now, what are the auscultatory findings of Truncus? We have a single S2, logically we do not have two valves there. We have a systolic ejection murmur because of increased flow, and given the fact that this structure can become insufficient, we can also have truncal regurgitant murmur, which similar to other bicuspid murmurs of aortic or pulmonic regurgitation is early diastolic. What would be the pulse resultant of such regurgitation? Similar to conditions with aortic regurgitations, we may have bounding pulse. What is the most feared complication of Truncus arteriosus? Pulmonary hypertension, and therefore this condition also requires early surgery, similar to what we had in transposition. Okay, moving to our next condition, and that's hypoplastic left heart syndrome. Before that, what other condition among the cyanotic congenital heart diseases that we have discussed so far, if not corrected by early surgery, would also result in hypoplastic left heart? That's transposition of great arteries, because the left heart is pumping into low resistant pulmonic circuit in that condition. Now, I would like to begin our discussion of hypoplastic left heart syndrome by reminding us that I mentioned all of the cyanotic congenital heart diseases, perhaps with the exception of Truncus arteriosus that has total mixing and therefore mild cyanosis, are one way or other dependent on a shunt and usually described as PDA dependent, which is the most common type of shunt. How this analysis is relevant to hypoplastic left heart syndrome? Well, in hypoplastic left heart syndrome, right ventricle supports both pulmonary and systemic circulations, and therefore survival depends on presence of a couple shunts, definitely PDA, but also preferably ASD. Now, what's the physiology or pathophysiology of it? Well, we have underdeveloped everything in the right side. It's underdeveloped left ventricle, underdeveloped left-sided valves, underdeveloped ascending aorta, and aortic arch. Is left atrium also underdeveloped? Not necessarily, because the return of pulmonary veins to left atrium is not impaired, but everything ahead or distal or downstream left atrium is hypoplastic, and therefore we probably have a very large left atrium. What is the common feature of PDA-dependent cyanotic lesions? Possibility of acute heart failure or even shock at around day 3 to 5 upon closure of ductus arteriosus. Please always remember this. It's not specific to coarctation where we discussed this. It could happen with any of the PDA-dependent cyanotic conditions. Now, if you are said to have a patient with hypoplastic left heart syndrome who has both PDA and ASD, you may be asked what's the direction of the shunts, or you may be asked which one of the so-called cyanotic congenital heart diseases could have both right to left and left to right shunt, and that is hypoplastic left heart, because while the PDA is from the high pressure, high flow pulmonary artery to aorta, and therefore a right to left shunt causing gray cyanosis, the ASD is the one that pumps the blood from the left atrium to right atrium, and the reason is because, as I mentioned, everything ahead of left atrium but not left atrium itself is hypoplastic, and therefore again the central dogma of cardiovascular hemodynamic physiology says we have increased flow upstream or proximal to the point of stenosis or hypoplasia, and that means we have increased flow and pressure in the left atrium, which is proximal to the hypoplastic heart. What's the finding on chest wall or precordial palpation in hypoplastic left heart syndrome? We have increased right ventricular impulse logically, as it bears the responsibility of both chambers. In other words, we have this right parasternal lift on the location of the right ventricle, of course, on the heart area. Are we dealing with any type of pulse differential or cyanotic differential here? No, contrary to coarctation, we have weak or no pulse in 4 extremities, and we have gray cyanosis, that's severe cyanosis, without differential. Again, based on what I discussed, what you expect to see in ECG of hypoplastic left heart syndrome: right atrial enlargement because of the shunt of ASD pumps the blood to right atrium, as well as tall P waves and weak left ventricular impulse. Now, what's counterintuitive in chest x-ray of the so-called hypoplastic left heart syndrome? Remember, the size of the heart could be small, normal, or large. Why heart could be large or even globular? Because not only patients may have early heart failure, but also because of the enlarged cardiac silhouette due to enlarged right atrium. What is the approach to surgical management of hypoplastic left heart syndrome? Given the strong association with several life-threatening extracardiac and chromosomal abnormalities, those conditions first need to be ruled out, and then a couple surgical approaches such as septostomy and palliative shunt formation are the recommended surgical options. In other words, we try to create something similar to Truncus arteriosus by manipulating and digging a hole into arterial septum between the aorta and pulmonary arteries to allow some circulation in the aorta. Once more, what shunt is required for survival? In hypoplastic left heart syndrome, even though we may have PDA, what determines possibility of survival is a form of interatrial shunt, specifically atrial septal defect. Otherwise, oxygenated blood have no way to reach any circulation. Okay, this is the right time to discuss total anomalous pulmonary venous return. Now, what is the pathophysiology in TAPVR? Pulmonary veins drain into the right-sided venous return elements. That is how I want you to understand it. Now, right-sided venous return elements are SVC, IVC draining into right atrium. A common form of it is pulmonary veins draining into right atrium, but it is also possible that pulmonary veins drain into SVC or even cross the diaphragm and drain into IVC. Sometimes they may even drain into coronary sinus on their way to right atrium drainage. Put it simple, right atrium receive venous return of both right and left circulation. That means what changes in heart chambers? We will have right atrial enlargement. Do you remember another condition with right atrial enlargement among the ones we discussed? Yes, that was hypoplastic left heart syndrome. What's the other similarity of TAPVR with hypoplastic left heart syndrome? Left atrium and left side of the heart are in general not functional and underdeveloped. What are the two main types of total anomalous pulmonary venous return? Obstructive versus non-obstructive type. What is the obstructive type? When there is a form of obstruction in the pulmonary veins on their path towards the anomalous destination, and this would translate into extreme elevation of pressure within the pulmonary veins with early pulmonary hypertension and heart failure, while the non-obstructive type is associated with just total mixing of the blood without cyanosis. One may wonder why we even categorize TAPVR as a cyanotic condition, while in effect it is actually a left to right shunt. And the answer is, for the patients with TAPVR to survive, there needs to be a type of right to left shunt, either a PDA or an ASD, to shunt some degree of this mixed blood into the systemic circulation. So pay attention to the fact that even though the initial shunt is an anatomic malformation resulting on deviation of the left-sided venous return to the right-sided chamber of right atrium, it is categorized as a right to left shunt because there is a form of PDA or ASD that shunt the blood, this time from the right to left direction. Remember, the pure ASD as an acyanotic condition was a left to right shunt, but here we have an ASD that shunts the blood from right to left. I remember in the ASD episode I mentioned the direction depends on the pressure of the atrial chamber. Now, I mentioned that we have sometimes just one word that can help us diagnose these cyanotic conditions. That one word in chest x-ray of total anomalous pulmonary venous return is snowman appearance or figure of 8 appearance. And what is it exactly? It is this supracardiac vein or brachiocephalic vein that receive the venous return together with SVC that form the head of a snowman, and enlarged right atrium in cardiac silhouette forms the body of the snowman together, forming this snowman appearance on chest x-ray, especially for the most common subtype of TAPVR, which is the supracardiac type. What is the second finding in all types of TAPVR? That's increased pulmonary marking because of the backflow, especially in the obstructive type. Again, as I mentioned, right atrial enlargement and right ventricular hypertrophy is possible, and this will translate also on ECG as tall P waves. As I mentioned, the survival depends on a form of right to left shunt such as PDA or ASD, and that is why treatment begins with maintaining the patency of PDA by administration of PGE1, and then this high mortality surgical corrective procedures if plausible. Okay, we have just 2 more conditions left. That's Tricuspid Atresia and Ebstein anomaly. What is Ebstein or Ebstein anomaly? Remember, it's the downward shift of the tricuspid valves with what resultant chamber size changes? Well, if that valve is downshifted, we will have a smaller right ventricle and larger right atrium. Also, this valve will be dysfunctional. So what is the clinical picture? We will have tricuspid regurgitation with the whole systolic murmur in the lower left sternal border. What is the well-known risk factor? That one word, if you are looking for, is maternal lithium exposure. So look for mother who has taken lithium during pregnancy by any mistake for bipolar disorder or any other reasons. Presentation could be early cyanosis in a severe form with heart failure, or later on manifest with arrhythmias. Now, if you are said that you are dealing with a box-shaped heart, what will be the cyanotic condition? That's Ebstein anomaly. Remember, globular heart was seen in what condition? In hypoplastic left heart syndrome. What about boot-shaped heart? That was tetralogy. What about the figure of 8? That was the snowman or figure of 8 of total anomalous pulmonary venous return. Here we say in Ebstein we have the box. You can probably remember a prisoner who was also put in a box or in a jail with the same name. Okay. What is the mechanism? Think of the box-shaped heart as just extreme enlargement of the right atrium. That's the right atrium enlarged, and right ventricle is relatively smaller than the normal size. Now, what will be the focus of the treatment in Ebstein anomaly? Please remember, if any of the cyanotic conditions have the strongest association with arrhythmias, and therefore management of arrhythmia takes precedence over any other management, that's the Ebstein anomaly. That's the management, again, if the arrhythmia is present. Otherwise, we manage it similar to other cyanotic conditions with prostaglandin E1 and creation of a temporary shunt. Now, again, a tricky condition. Why this Ebstein anomaly is considered a right-to-left shunt? The misplaced tricuspid valve translates into tricuspid regurgitation, and this translates into enlargement of the right atrium, again due to increased volume and pressure on right atrium because of the regurgitant flow. And this means, as we described, a possibility of right to left shunt across a patent foramen ovale. And that is why Ebstein anomaly is considered a right to left shunt. Finally, tricuspid atresia. Again, similar to Ebstein anomaly, we have this right ventricular hypoplasia and resultant pulmonary atresia, especially if the patient does not have ventricular septal defect. And again, why is it considered a right to left shunt? Because survival requires patent foramen ovale, ASD, or any other type of supportive right to left shunts. Why is it a right to left shunt? Because right atrium has no way for forward flow because of the atretic tricuspid valve between right atrium and right ventricle. Now, if there is a VSD and you are asked to analyze the directionality of shunt of PFO and VSD in tricuspid atresia, what's your answer? Well, in the PFO, it will always be moving from right to left. However, if a VSD is present, given the fact that the right ventricle does not receive any blood, any venous return from the right atrium, the pressure of left ventricle will be definitely higher than right ventricle, and therefore it will be a left to right shunt through VSD. And that's actually required for survival. Otherwise, there will be no circulation on the right side of the heart. And given the fact that the system is in series, it means complete absence of cardiac output, and it will not be compatible with life. Now, what is the specific ECG finding in this tricuspid atresia, or if you have a cyanotic congenital heart disease with a very peculiar ECG finding. What is it? That's left axis deviation. Always remember that the axis of the electrical activity of the heart will be deviated to left or right for either increased bulk of cardiac muscle in that side or decreased bulk of cardiac muscle in the opposite side. In this condition, we have right ventricular hypoplasia, and even though we do not necessarily have left ventricular hypertrophy, which is the more common cause of left axis deviation, because of the decreased electrical vector of the right side of the heart, we have this left axis deviation. This is again one of those one-word descriptive findings that can help you differentiate the diagnosis of tricuspid atresia. What about the other ECG findings? Well, you remember that the R wave on the right-sided precordial leads correspond to the right ventricular electrical activity and action potential. Now, if we do not have much bulk of the right ventricular myocytes, the R wave that corresponds to electrical activity of right ventricle will be small, and the best location to perceive the right wave is of course the right-sided precordial leads such as V1 to V3. The opposite is we will have compensatory increased signal on the left ventricle, so that is another consideration. What do you expect to see in the chest x-ray of tricuspid atresia? Well, always remember that similar to pulmonic stenosis, any condition with a atretic or stenotic valve would have reduced flow distal or downstream the point of increased resistance, and therefore we have decreased pulmonary markings. We may have therefore normal heart size. Now, even though we mentioned that patent foramen ovale can function as a physiologic means of survival, what is the general management approach to tricuspid atresia? We usually need a balloon atrial septostomy as a temporary measure before the definitive surgical intervention. I understand that there was a lot of conceptual material to be addressed here, but I tried my best to make as few memory dependence points and make it prone to analysis when it comes to auscultatory findings, chest x-ray findings, and ECG findings, as well as dependence on the shunts and directionality of the shunts. So that is the way you would benefit from analysis of the findings instead of depending on memory, because there's so many overlaps. Just try to remember the one or two very specific either risk factor or chest x-ray findings or the auscultation findings that can help differentiate these conditions. And this was our discussion of 9 cyanotic congenital heart diseases. Thank you.